Hello, everybody, and welcome to the IOCDF Research Roundtable, the IOCDF live stream where we pick an interesting topic within the OCD literature and talk about it with the folks who know it best. My name is Kyle King. I guess this is normally the part of the show where I would say I'm a student at Yale University, but kind of not anymore. I graduated a little less than a month ago at this point, which is pretty cool. But now I'm an incoming student at the School of Medicine, so I can't leave New Haven no matter how hard I try. I've spent most of my undergrad years studying OCD. Boris popped on the screen for a second there. Studying OCD because one, I think it's a really interesting disorder. I think it's really multifaceted and complex, and I'm just interested in it in general. And two, because I have it. So selfishly, a lot of the treatment and a lot of the new information about his pathophysiology is very interesting to me. Normally, I'd gesture to my co-host, John Abramowitz, at this point. John, unfortunately, couldn't be here with us today. He'll be on the stream next time. Hey, John, if you're watching after the fact. But it's all good. We have three presenters here, or not, three panelists here, rather, who certainly have a lot to say about the topic. And our topic today is body-focused repetitive behaviors, or BFRBs, which I'm really excited to talk about because having worked in OCD for a while and interacted with a lot of folks in the OCD clinic, I feel like BFRBs come up a lot and they're discussed a lot, in rounds, but they're normally discussed in a tertiary sense or kind of secondary to our discussions of OCD. And I feel like I haven't spent a lot of deliberate time trying to understand BFRBs and disorders that center around BFRBs. So I'm excited to dig into that with people who think about it a lot more than I do. Before I introduce our panelists, I do have some announcements that I need to make. First, this live stream is educational and is not intended to replace therapy. For treatment-related questions, please work with your provider or contact a local clinician. You can use the IOCDF's online resource directory at iocdf.org/find-help to locate a trained clinician near you. Also, the International OCD Foundation is not a crisis hotline. If you're in a crisis or if you're ever feeling suicidal or unsafe, please call the 988 Suicide and Crisis Lifeline by dialing 988. You can also access this online at www.988lifelines.org or go to your local emergency room or call 911. Also, we have a live chat feature. We love it when you put questions in there. I'll try to get to as many questions as we can. Sometimes I'll ask questions 20 minutes after you post them, but I promise I'm reading them. Just know that everything you put in there live and it stays on the internet forever. So just be respectful in the chat. We've never had a problem with it, but I like to mention that at the front. Okay. Now I feel like I've said enough words. I'll start introducing our presenters. The first bio I have here is for Dr. Olfson, Emily. Dr. Emily Olfson is an MD PhD. She's a physician scientist who conducts clinically oriented genetics research on several child-onset neuropsychiatric conditions, including body-focused repetitive behaviors. She received her MD and her PhD in human and statistical genetics at Washington University in St. Louis and completed her residency and fellowship training in child, adolescent, and adult psychiatry at Yale. Dr. Olfson works clinically with adults and children in the TIC, OCD, ADHD, BFRB program in the Yale Child Study Center. Certainly a good person to have on this panel. We told you backstage, Emily, that I typically ask a kind of weird warm-up question. So I'm on summer break right now. It's raining. I wish I could be outside. But if it weren't raining, I'd probably be playing spike ball. What's your ideal summer break activity?
Well, first, thank you, Kyle, for the opportunity to be here today and to talk with this audience about what I think is an important topic that deserves more attention than it often gets. So I'm delighted to be here and with these terrific other panelists as well. So on a summer day, you must not be in New Haven right now because it is not raining here. But my favorite thing to do, I have 3 kids, young children, and I love to take them to the beach. So that would probably be my favorite.
Really?
thing.
Even the Connecticut beaches?
Even the Connecticut beaches. I prefer to go up maybe to the Cape Cod, Boston kind of area, which is just the right amount of a drive with 3 young children, where you feel like you're getting away and you could see the ocean. But that is probably my favorite thing to do.
I went to like the Connecticut beaches once in my freshman year and then decided that they don't compare at all to Florida and it's just not worth going to. Um, but I respect the call. Our next panelist is John E. Grant. John is a professor of psychiatry and behavioral neuroscience at the University of Chicago, where he directs a clinic and research lab on addictive, compulsive, and impulsive disorders. John also wins the award of shortest bio ever on this show, which I like because I have to say the least words. Also, John, you don't know this, nor do my parents, but when I was like in high school, I read something you wrote about deep brain stimulation for OCD, and that's one of the reasons that I wanted to go into neurosurgery for most of college, and I'm still considering it. So your name is like emblazoned in my brain. But anyway, thanks for being on the show. Same question for you. What's your ideal summer activity?
Oh, I stay out of the summer. It's a good time just to stay indoors.
Okay, interesting. So what's your ideal indoor summer activity?
Just taking some time to read, I think. So.
Okay, that's not the answer I was expecting, but I guess for someone in Chicago, maybe I should have been expecting it.
It's a lovely place, Chicago, but yeah, everyone likes different seasons. I prefer winter. So.
Oh man, we can talk about this offline. I strongly disagree. Our final panelist is Katie Barber. Katie is a doctoral student in clinical psychology at Marquette University. Her research interests are focused on the mechanisms underlying the development and maintenance of trichotillomania and skin picking disorder. Katie works under the mentorship of Dr. Douglas Woods at Marquette and also works with Dr. Han-Jo Lee at the University of Wisconsin-Milwaukee. Before starting her PhD, Katie worked as a research assistant at Penn State University and earned a master's degree in counseling. She completed her master's level internship at CBT Baltimore, a clinic specializing in the treatment of OCD and related disorders. Katie, thank you for being here. I sincerely hope that you don't agree with John and you don't prefer winter. What's your favorite summertime activity?
Yeah, well, first, thanks for having me. Super excited to be here. I do disagree with John about winter after living in Wisconsin for the past few years. I'm not a winter fan. But summer activities, I've been getting into pickleball. So I'm going to go pickleball.
I love pickleball. I feel like me and my friends got into a disagreement about whether or not pickleball is fun because they were arguing it's not athletic enough. But as someone who's not terribly athletic, I think it's plenty athletic.
Yeah, me too.
All right. Well, thank you all for being here and for bearing my weird questions. Let's get into the meat of the discussion today. When I was kind of rehearsing what I was going to say in the intro, I was thinking about BFRBs, and I guess when I think of body-focused repetitive behaviors, I immediately was thinking about like trichotillomania or skin-picking disorders. But when I was like rethinking the term body-focused repetitive behaviors, it doesn't necessarily imply, at least like at face, a disorder. It just implies like a behavior. So I guess I wanted to start super basic with my questioning because I don't know a lot. What is a BFRB?
I can start. So body-focused repetitive behaviors are, in fact, repetitive behaviors focused on one or more parts of the body. So they're pretty aptly named. Often things like hair pulling, skin picking. And you're right, like when we talk about BFRBs, the behaviors themselves aren't necessarily disorders, and the behaviors are pretty common, like in the general population. But we're often referring to the disordered form. So once BFRBs are causing significant distress or impairment or both, that's when someone might be diagnosed with trichotillomania or hair pulling disorder or excoriation and skin picking disorder.
Okay, and just trichotillomania, that's a reference to hair pulling disorder?
Right.
Okay, just so that everyone's clear, because all these words are kind of new to me. Okay, so when you say body-focused repetitive behaviors, we're not necessarily talking about a disorder yet. Are these fairly transdiagnostic?
What do you mean?
Like, will body-focused repetitive behavior show up in a number of disorders across the DSM?
I guess they can. Like skin picking is sometimes a symptom of body dysmorphic disorder. Although we're often talking about like trichotillomania or skin picking as their own disorders.
Okay. So I guess what are the clinical markers of something like trichotillomania or excoriation disorder?
So I can let Katie be off the spot for a second. So trichotillomania and excoriation disorder are right now in the DSM-5 classified as obsessive compulsive and related disorders. So they're two kind of body-focused repetitive behavior disorders that are their own entities within the DSM-5. And trichotillomania actually was reclassified in the DSM-5. It used to be an impulse control disorder, and excoriation disorder, skin picking disorder, was newly added at that point. And so these are when these, BFRBs are, taking either, causing significant impairment or distress, as Katie said, and, leading to hair loss or skin lesions and things like that. So once they become kind of impairing is when we diagnose them as the disorder.
But also to Katie's point that some people do pick as part of body dysmorphic disorder. Some people will pull their hair for symmetry purposes, to even things out or to hide other perceived blemishes or problems in body dysmorphic disorder.
Mm-hmm.
People with stimulant misuse, cocaine, methamphetamine, will often pick as a symptom of their stimulant use. So that the behavior itself kind of, is transdiagnostic in some ways. And so when somebody comes in with picking or pulling, the key is to figure out if it's a symptom of a different problem or an independent, as Emily mentioned, an independent disorder with its own sort of criteria, such as trichotillomania or skin picking disorder. So,
and what's kind of the key to parsing that out? Like, if someone comes in and they have, I guess, like little open marks on their skin, like, what do you ask John when someone walks in?
I think having a discussion about why people pick, what's sort of the driving force behind it, if they're aware of it, if they're using substances, would be the other piece. But you do want to know, I think the difficult differential, if you will, between is to understand whether the picking, particularly is an independent skin picking disorder or body dysmorphic disorder. And quite frankly, folks can struggle with both at the same time. So they might pick some spots, sort of unaware that they're picking. They're not really always sure. And other times they're picking very intentionally to correct what they perceive as a defect or a problem with their appearance, even if there isn't one to outside observers.
Okay. And Emily, I wanted to follow up on something you said. Why was trichotillomania moved from an impulse control disorder, I think you said, to an OC? Like, I don't know what that distinction implies, or why they'd make that switch.
Well, I wasn't on the DSM committee, so I don't know exactly what went on their discussions. I'm assuming, both these conditions, trichotillomania and excoriation disorder, do commonly co-occur with OCD, and they have some kind of similar characteristics. There's some, not a lot, but some evidence that there's similarities in terms of the genetics and the neurobiology and things like that. And so I think it was thought to be an appropriate putting them together in that group. Mm-hmm. I think, though, there's still a lot of unanswered questions in the field, and whether I work in genetics, so this is something I feel I'm very interested in, whether it will actually be similar to OCD, or whether it will be similar to like a tic disorder. We don't know yet. But that was kind of the change. And it's with, in obsessive compulsive related disorders, there is also, as John and Katie were talking about, body dysmorphic disorder is there, hoarding disorder, etc.
As it stands now, it's like does it look like the genetic evidence is kind of lumping these disorders, excoriation and hair pulling, with OCD mostly?
Well, again, we don't have a ton of evidence. The biggest twin study that was done, that was published almost a decade now ago, looking at a twin registry study, looking at obsessive compulsive related disorders, found that there were some genetic factors that seemed to be shared across the OCD spectrum when they did this kind of latent factor analysis. And then there were also some genetic factors that seemed to be more specific to trichotillomania and skin picking disorder. And so there seemed to be a lot of kind of genetic overlap in those disorders. And that's often why, so we think of them, so often when we talk about these disorders, we talk about them in general as obsessive compulsive related disorders, but then we often subclassify these together as these BFRB disorders because we think there are a lot of kind of similarities between them phenomenologically. So yeah.
Yeah, so I guess since you brought up the similar, like what are the phenomenological similarities between OCD and BFRBs, and then what are the differences?
Right. So, in terms of, I'll start with a slightly variant of that question. So in terms of the similarities between skin picking and trichotillomania, I mean, by definition, they're very similar, right? Mm-hmm. So it's pulling or picking at one's own hair or skin, leading to skin lesions or hair loss that leads to impairment or distress. So they're kind of very parallel. The DSM definitions are very parallel between the two disorders. And they do commonly co-occur together. So oftentimes individuals who have one body-focused repetitive behavior, also, if you ask, they'll have other ones as well. And not even just skin picking and hair pulling disorders, but also things like nail biting and, other types of BFRBs. And then in terms of with OCD, they do have a high co-occurrence rate as well with the disorders. But I know you've spent a lot of time talking about OCD on this forum, so I won't go through the definitions of that. But I think kind of based on the co-occurrence and based on, as I've talked about, some of the data looking at phenomenology.
Then also I could jump in with kind of comparing, contrasting OCD and BFRBs. So like surface level, we're seeing repetitive behaviors in both BFRBs and compulsions in OCD. But it seems like the function of those repetitive behaviors is what differs. So in OCD, trying to relieve obsessional distress, prevent something bad from happening. So the compulsion is providing negative reinforcement, like reducing that distress. Where sometimes with BFRBs, there is negative reinforcement, like someone feels anxious and picking their skin relieves that anxiety. But there's a lot of different functions that BFRBs can serve. So sometimes they just feel good. So there's positive reinforcement. Someone's getting like a pleasurable sensory sensation. Or like I said, like sometimes it's anxiety, but the anxiety isn't as directly linked to the behavior as we typically see in OCD, where it's like the obsession and like compulsion. With BFRBs, often it's more like general emotion dysregulation or just not feeling great, being stressed about other things, and then picking or pulling or whatever BFRB you're engaging in provides some comfort or relief, something like that. Yeah, there's a lot of different functions that BFRBs can have.
I think that speaks to, when we talk about these BFRBs, I think the cautionary tale is that they're not sort of monolithic ideas. Not everybody with trichotillomania is identical. And so you'll find many folks who have, say, trichotillomania or skin picking who seem very identical to somebody with OCD. They'll talk about it the same way. It'll seem to sort of be clinically presenting in that way. And then other people will describe their hair pulling. I mean, kind of to Katie's point about the reward, they might say, I feel like this is an addiction, right? I just feel so driven by this and I love doing it. And I feel satisfied when I get the right hair pulled or, something coming out of, a pore and I get something pus or something out of it. And so, we just want to, I think, be very mindful that although that we call them a disorder, it doesn't mean that everybody with them is the same. And that may also speak to some of the disconnect why some people say, I don't feel like my hair pulling has anything to do with OCD. And
Yeah.
like, yeah, you're right. It probably doesn't. And yet the other person that was just here 10 minutes ago, theirs might. And so there's a lot of sort of heterogeneity or differences within the disorder that may drive the behavior for folks.
Yeah. Well, okay. This opened up a can of worm questions, I guess, in my head because it got kind of confusing. And I kind of confused like Amy at 1220 who just asked, so there can be different functions for the behaviors involved in BFRBs. I didn't realize they could sometimes in some people serve like a positive function, like it felt good to pick or hair pull. So like, I guess, do people presenting as that, do they want to stop? Like, is it ego dystonic?
I think people can be quite ambivalent about it. They may not want the damage from what it has done to their skin or their appearance. They may not want the alopecia or the bald spots, but they also find some reward, let's say, or benefit on some level in the immediacy of doing the behavior. It helps them zone out. There are lots of kind of differences in reward that people may get from any number of behaviors. So
there's also like heterogeneity within people with a BFRB. Like maybe sometimes they're engaging in the behavior because it feels good, and then other times maybe it's stress or tension or it's habit. It's just happening automatically. Whereas like other times maybe it is to get that feeling of pleasure or gratification.
My clinical experience is similar in that I think it can be very mixed. There can be a lot of guilt and shame associated with doing the behavior and the consequences. But then when you really dig down in the questions about why it continues, there is something reinforcing about it and there's some relief. And so that's partly why kind of the therapy focuses on kind of the replacement as well. And I think it's very important, when you're working with individuals who struggle with these to really understand these differences because it allows you to kind of tailor your treatments as well.
Yeah, I'm trying to understand them myself. Okay, so there's subsets of people whom they like feel some positive reward from doing this that feels good, but is it connected to like anxiety and it reduces the anxiety of something like an OCD, or is it different?
Well, there can be like a relief in a similar way, like a feeling that they have to kind of complete it. It's not necessarily always associated with anxiety. I think this kind of gets at the heterogeneity as well. So sometimes people are more likely to pull or pick actually when they're relaxed, when they're just kind of zoning out. So I don't know if others want to comment as well.
I think there is something rewarding about, I think it's very human nature, right? I mean, for some people, if you feel that there's something sort of a little bit like OCD, if you feel like there's something odd about a particular hair, for example, it's odd, it feels strange and kinky. Tunk, I've gotten it out. I love that. It's a sense of accomplishment. Again, it comes with, as Emily has mentioned, a lot of shame and embarrassment about that. But I think most of us do that, right? You have something strange on your body, you pick it off or you get rid of it and you're like, good for me. One of the differences is that people with BFRBs, one thought is that their off switch doesn't kick in as well. And so it keeps repeating, whereas most of us would pick something for a number of reasons, getting rid of it, a sense of completeness, etc. And then we're like, okay, I'm done. I need to go on to do something else. And they can get really lost in that sort of never-ending sort of, need for yet another one that they get rid of with a sense of accomplishment, etc. So.
And to your question about anxiety, there's in some research looking at this, where there's a recent meta-analysis that showing that hair pulling and skin picking, their associations with anxiety are lower than some of the other obsessive compulsive related disorders. So that seems to be something that's differentiating these disorders from the rest of the gang. So
if you ask folks with BFR or excoriation or hair pulling, well, sometimes they say like that there's no explicit thought as to why they're doing it. It's just kind of happening. Like,
yeah, some people don't realize that they're doing it until after it's happened.
Yeah. We often actually, traditionally, a lot of these behaviors will characterize them as whether they are automatic or focused. And so automatic kind of pulling or picking kind of is usually outside of their awareness, whereas focused is they're really aware of it. Sometimes, they may use tweezers and a mirror. And so they're, it's intentional. And most people have a mix of them. They may have kind of more of one type or another, and there might be patterns. And usually the first step in the therapy is actually to try and raise the awareness of it, right? So that you can intervene, so that they're aware that they're doing the behavior, the awareness training. So
am I right in thinking like what kind of groups BFRBs or disorders that stem from BFRBs together, like excoriation and hair pulling, it's less like the why, like less the I pick it because it feels rewarding, or I pick it just because I'm not thinking about it, but it's just happening, and it's more like that I'm picking something and that's causing some level of distress in my life. Like it's more the consequence that's like the thing you look for if you're trying to diagnose something like this.
Right. Yeah, I think that's something interesting that sets it apart from OCD too, whereas OCD is like the compulsion is happening because of this, but our diagnostic criteria for trick and skin picking are like the presence of the behavior, attempts to stop it, and then distress and or impairment. And that's it.
So like,
or like differentiating it from, no substance use or other medical things that might be causing it.
So what happens in the case of like, someone who's picking their skin for symmetry purposes, and like they end up with the same result of like having lesions, and they pick their skin more than they would like, but it's for this expressed obsession that like they want to have symmetry for X reason. Is that like OCD, or is it a BFRB? Is it a pointless distinction for me to be trying to make right now? Like,
it's hard without this hypothetical person in front of us to talk to get more.
I guess like what questions would you want to ask? If any of you guys have thoughts.
Well, I think if it's in the case you give as symmetry is the driving force, right? So the lack of symmetry is causing some level of anxiety and distress because it's wrong that there's a lesion here and there isn't something here, etc. Then, I think that would fit under a much more classic understanding of OCD with the picking as a compulsion. And I think for years that is often why historically trick and picking got sort of subsumed under OCD for a long time. People sort of assumed, well, there must be some obsessive state driving it, because in some people there is, as in that example. And then you would focus on the obsessions, right? As from a cognitive restructuring standpoint, you would work on ERP to stop the actual compulsive behavior. And I would argue that you'd probably start with treating that much more like a classic OCD example. But what we've learned over the years is a lot of picking and hair pulling isn't driven by these obsessive thoughts, that it's sort of a stand on its own kind of repetitive behavior that may have some thoughts, but not obsessions, not preoccupations necessarily. I'm not thinking all day about necessarily, something and then I have to relieve it with this. I may just be doing it. But it has fallen in this interesting sort of, I think, between the cracks of things, which has confused our understanding of hair pulling and and picking over years, as Emily mentioned? Is it sort of a tick-like in some people? Is it sort of this? And it's always getting this sort of understanding. And I think that's, due to a large extent that you can add up all the people that have been studied over the last 30 years with a BFRB, and they're probably a smaller number than in one large clinical trial of OCD, right? I mean, so that we really have lacked, we just need more time to sort of do this. So I think we end up with a lot more questions in the BFRB world than answers. And we try to kind of maybe fit it here. And then we find out a few more research studies saying, yeah, maybe not, maybe fit it this way. And so it's always in flux as far as I'm sort of concerned.
Yeah. So maybe one of the reasons why I'm confused is because I'm trying to relate it or think about it in context of some different disorder when I should be thinking about it as a standalone thing.
I think so. I mean, and to the DSM-5 point, there were some of us on the committee who raised the issue of maybe BFRB should be their own chapter in the DSM-5. Really? But people basically said 2 disorders in a chapter, we need more. So no, you'll just go into, I mean, it was more of a administrative issue than a scientific issue at the time. But we may find for DSM-6 or DSM-7 or ad infinitum, right, that maybe skin picking and trichotillomania are what, at least I've always suspected, sort of their own thing that on the edges like other things, but are their own thing.
So this may be redundant, but Amy asked something in the chat a little while ago. So some BFRBs are not related to OCD. I'm confused. She said at 12:21. I'm still confused as well, Amy, a little bit. So is the relationship to OCD that I perceive BFRBs to have, is that a historical artifact more than, maybe something that is clinically important?
I think that's kind of the big question that a lot of people are trying to figure out.
What's your guys' take on it? You guys just...
Yeah, there's not a ton of research directly comparing OCD to trick and skin picking. There's a handful of studies, so it's hard to kind of draw conclusions from the limited research. It does feel like kind of this adjacent, separate thing, at least in my head.
Mm-hmm. I think it's sort of, what's your goal of classification, right? I mean, when the ICD, the International Classification of Disease, with the World Health Organization, which I volunteered for, and when we were thinking about where to put hair pulling and skin picking, the goal was different. It was based on, well, who treats it? Who will treat it? Who's going to be screening for it? Mm-hmm. Because what we want is greater recognition for people who struggle with it. We want them to be able to get help. If that's your goal, then putting it with OCD for right now is great, because it's the OCD researchers, the OCD clinicians, therapists, and doctors who have an awareness of the BFRBs. So they are the people that are most likely to be able to do a good diagnostic screen for it and understand appropriate treatment. So I would say right now, I love having it in that category because it's a home that works for people who struggle with BFRBs to get the help they need. If scientifically we find out over the next X number of years that there are lots of differences, then we'll classify it differently for different purposes, maybe.
Yeah. And Emily, I'm going to shoot a question over to you. I guess now I'm thinking we talked a little bit about the genetics, and it seems unclear. Is there, do BFRBs seem similar to OCD or some other disorder neurochemically or biologically, or do they also kind of feel like this separate entity?
Well, I mean, there are many ways. I think you don't have to just answer that question with genetics. So I may throw it back to some of my colleagues as well, because I think one of the ways to also think about it is what treatments work, right? Yeah. We have 2 experts on that. John Grant is probably the expert in the world in terms of pharmacology for treating BFRBs. and done most of the clinical trials. But one thing we know about them is actually a lot of the treatment, the standard of treatments that work for OCD, SSRIs, which are kind of the go-to medication, really don't have an effect on BFRBs, right? At all. They help with the co-occurring kind of anxiety and depression. So oftentimes individuals who have BFRBs, they'll benefit for their other kind of co-occurring conditions. But when you actually look at the data about helping the hair pulling or skin picking, SSRIs don't help. And there are a few medications that have been shown to help in 1 or 2 clinical trials, but there isn't a lot of robust data in terms of medications. And so in that sense, it's a little different. And then I'm going to throw it back to Katie, who does a lot with kind of the behavioral therapies. The behavioral therapy approach is actually, what we often use, this COMB, is kind of more similar to CBIT, which is used for treating tics, than it is ERP. Okay, I'll go through these. So is comprehensive behavioral treatment for trichotillomania or skin picking disorder. And it's more similar to the comprehensive behavioral treatment for tics, CBIT, that is used than exposure and response prevention, than ERP, which is kind of the standard for OCD treatments. So a lot of the treatments are actually, different than OCD. And I think actually that more than that, I know your question was about genetics, but we don't have enough genetic studies to tell you much yet. But I think even just looking at the treatments that work, there's got to be something that's different that's going on. I don't know if my colleagues want to add on to that, but.
Yeah, I'd love to hear more about the pharmacology and the behavioral treatment differences.
Yeah, so I can speak to the behavioral treatment stuff a little bit. So a lot of behavioral treatment for BFRBs involves habit reversal training, which is using a competing response or something that's going to block the behavior. And that's what we also use to treat tics and Tourette's and chronic tic disorder. And that's not really used for OCD. So that's something that is differentiating as well. Whereas, exposure and response prevention, we're focused on getting at the fear, the underlying belief, habituating to distress, or, inhibitory learning. And that's not really the approach that works for BFRBs, often because that fear and anxiety piece isn't there. So we're more focused on addressing the overt behavior, but then also adding in other things to address if the behavior serves an emotion regulation function, or if there are thoughts that are contributing to the behavior, adding on different interventions. It's very personalized to each individual and the functions that their BFRB serves for them.
Okay. So the behavioral treatment is going to be mostly thinking about just what is the overt behavior? What can we, how does habit reversal therapy work? I think I read something about habit reversal therapy when I was studying up a little bit. Or can you, since clinicians watch this, what's kind of the standard of treatment?
Yeah, so just to sum it up really quickly, I guess, you want to increase
years of work very quickly, please.
Yeah, my mentor is gonna love this. So you want to increase awareness of the behavior, so that they can do something before it starts. So increasing awareness of when the behavior is happening, what all the movements involved in it, and then teaching them a competing response or a different action that blocks it from happening. More of my clinical experience is actually working with tics, but it's a little bit different. So maybe if someone is pulling their hair, their competing response is holding a fist down at their side, because that's going to block them from being able to put their arm up and pull their hair.
And then just sitting with the feeling that I want to go pull my hair, and just kind of
right.
Let it die down.
Yeah, at least the habit reversal portion of treatment, that's what that would look like. Usually habit reversal on its own does not address everything for people with BFRBs because of all those different functions that the behavior serves. But that's just one piece of getting at the overt behavior.
Mm-hmm. And then if habit reversal doesn't do everything, sorry to keep grilling you, Katie. But your mentor will like it, I promise. So like, if the habit reversal doesn't do everything, what are the other pieces that you might work in for someone with BFRBs?
Right. So the COMB model, that's a comprehensive behavioral model that addresses like sensory, affective, cognitive components. But then research has also combined habit reversal with components of acceptance and commitment therapy. I had a paper recently published looking at long-term outcomes of acceptance enhanced behavior therapy for trichotillomania, and it works okay-ish. People have also combined habit reversal with dialectical behavioral therapy. So these treatment modalities that get at the affect, emotion dysregulation, things that might be contributing to the behaviors.
And what do you mean by works okay-ish?
So we have like decent treatment response, but we also found that our control condition, which is psychoeducation and supportive therapy, those people also did pretty well, surprisingly well, not as well as the acceptance enhanced behavior therapy group. But it seems like maybe there's like more general therapy factors that are contributing to treatment outcome.
Mm-hmm. Just something about like psychoeducation in general might be good.
Yeah, or like that supportive therapy relationship, or being committed to doing something for something that you're struggling with, just increasing motivation.
Mm-hmm.
Starting to address the behavior can increase awareness on its own too.
Yeah. Okay. I see. I'll give you a break, Katie. I want to target John now for a second. Since, according to Emily, I have an expert here on the pharmacological treatment of BFRBs. Could you tell us a little bit about kind of like the literature about
to Emily's initial point, the SSRIs have really not been beneficial for skin picking and hair pulling. They might initially, for some people, reduce it a little bit because around the edges, they might reduce some anxiety and a little bit of an augmenting force, but they don't seem to have any sort of long-lasting effects on the core picking and pulling behavior. Now, having said that, there's one little exception in the mix. Clomipramine and Afrinil, which is the first drug for OCD, in the very first study for trichotillomania, did, in 12 people, did show some benefit compared to placebo. But, that is also not a classic SSRI. It has a noradrenergic, or a different chemical structure when it metabolizes in the body. So we kind of put that on hold. That may be doing something different in the big picture. But the couple of options that we've looked at that have gained a little bit of traction are more chemicals that work on, or more medications options that work on the chemical glutamate, arguably, if we ever really know what these drugs do. And one of those is a vitamin N-acetylcysteine, which the folks in South Carolina had studied actually for addiction. They studied it for cocaine addiction with some fair results. They used it for cannabis addiction with actually some more moderate results. It's been used as an augmentation in OCD when it's used with an SSRI. And so we used it on its own. And it did seem to help both people with picking and people with pulling. Maybe not successful in kids, but in adults, it was successful, and then a different drug that worked on a glutamate a little bit differently in the brain, an old Alzheimer's drug called memantine, which is also used in OCD as an augmentation. So again, it keeps begging us to find those kind of parallels, but differences, right? But when it was used without an SSRI, even it was beneficial for picking and pulling. Again, these studies are small, and to get to Katie's point about the help, sort of ish, right, somewhat beneficial ish, sort of response. Hair pulling and skin picking, in my opinion, they're very difficult disorders to treat, and we still lack a home run. We lack a go-to therapy that it works in a massive majority of people, or a medication. We clearly have nothing FDA approved from a medication standpoint, like OCD does. And so we really are still lacking those amazing outcomes. And maybe that will also tell us more. But I think that medication and the therapy being different from OCD allows us to kind of say, maybe we can think outside of the OCD box.
Mm-hmm.
Maybe we need to keep focusing, with a slightly different angle on these behaviors. We found, for example, an old alcohol drug was not beneficial compared to placebo unless folks with trichotillomania had family histories of alcoholism. And then it worked quite robustly in people. And so whether there are, again, differences within the group of folks with trick and picking, and so a medication that works for you won't be the same one that works for me. And as Katie has mentioned, the therapies are already being tailored individually. But I would argue we still need a lot more to go by in order to know how to tailor these things. We can't be doing necessarily genetics in sort of detailed cognitive assessments and all this. And we sort of lack any easy sort of understandings of how best, when somebody walks in the door, what we can do for them. So it's kind of, throwing spaghetti at the wall and seeing which piece sticks, right? I mean, which is not satisfying for patients.
And another challenge I completely agree with everything that's been said, but another challenge I want to highlight is not everyone has a Katie. There really is a shortage of kind of providers who are trained in these treatments, in these evidence-based behavioral therapies. I mean, I know there's a shortage for treating OCD, but there's even more of a shortage in providers who are skilled and have experience treating trick and skin picking disorder. And I think if there's any kind of take-home point, we just want kind of more people in the field studying these things and more people kind of doing these studies. We need bigger studies. And anyone who's in the audience who's participated in research before, thank you for doing that. It really does. It makes a big difference for this field, and it's really needed.
Yeah, some folks in the chat have expressed that they want to start doing studies, and there certainly seems to be a lot of interest. I'm really blown away by it. Seems like how little we know about these things, and how little we know about what's the best way to treat them. John, from a pharmacological perspective, I guess why did you say choose NAC? How do you go about thinking about what can we do to help someone?
Well, somebody had actually had told me at some point in early on, again, that these SSRIs weren't working. So once you realize that you don't have that option, you have to then read and figure things out. And my thought is I could either read all the OCD, what's going on in the OCD world, but that was all about SSRIs. But I had to think beyond that. And patients do tell us things that are incredibly beneficial. When people said to me, I remember one of the first young boys that I treated, about 15 years old. And he just said, I feel like an addict, from my hair pulling. And I thought, you squirrel away these little bits of characterization. And so then I was much more sort of initially drawn to the addiction literature to find out what people were doing. And so that's where I ended up with the work from South Carolina, who had done all the legwork on NAC, for example.
Yeah, it reminds me a lot of what you said about kind of these disorders existing within the cracks, and just someone relating it to something like an addiction disorder, and then saying okay, what works over there. Katie, you're now my behavioral treatment person. I'm sorry if that distinction's too much to bear, but I'm going to continue. Is there what are kind of directions that people in the audience may be looking forward to in terms of behavioral treatment, or are there BFRB specific behavioral treatments like trying to be developed?
Yeah. So I think we're trying to figure out how to adjust these adjusted treatments more, like for each individual, and figuring out like what predicts treatment outcome. Um, there's some research looking at neurocognitive factors, something that I was looking at in one of my papers, and a lab that I'm working with at another school, they're looking at response inhibition and if targeting response inhibition could, like before treatment, could then improve treatment outcome. So it feels like, at least in some of the research that I'm involved in, we're adding adjustments to these treatments rather than like starting from scratch with developing a new treatment. Yeah, it's a tricky area to figure out like what direction to go in.
Yeah, it certainly seems so. I'll switch over to some audience questions real quick because I feel like I should do that. Amy asked at 12:15, is it common for someone with OCD to have symptoms of a BFRB, but not to the level of a clinical diagnosis? It's for anyone.
I think lots of people have symptoms of BFRBs. We know just having hair pulling or skin picking, a lot of people in the population have them. And even the disorders themselves are relatively common. And we do know that they're higher in individuals who have OCD as well, which is partly why they were originally kind of grouped together, right? So
yeah. Although it sounds like the more you dig into this stuff, the more it sounds like that's kind of shaky at best. What is the overlap? Like, what is the percent of people with BFRBs versus percent of people with OCD who also have BFRBs?
I'd have to pull up the articles to give you exact numbers of them. I don't know if anyone knows offhand.
I think it's something like maybe like about 30% of people with BFRBs might have OCD, and maybe a little bit the other way as well, about 30. However, even that overlap, we see, upwards of that, if not more, folks with BFRBs who have ADHD and, et cetera, right? So the overlap with OCD has always been, there, and it's been commented on. But as we sort of screen and are aware of a lot of other things, particularly in adults too, right? When years before, when people thought ADHD wasn't something in adults. And so as we've gotten to look to a lot of other things, there may be overlap that's even greater in the BFRB world, which then gets you thinking, what does that mean, right? I mean, ADHD is high, to Katie's point, is sort of our aspects of impulsivity greater, right? And maybe there's a little bit more impulsivity in the BFRB world. Response inhibition is one cognitive aspect, but maybe we're seeing some of these ADHD-like sort of factors also roaming through at least a subgroup, which just complicates things more, right?
There's also some research showing that there's different rates for trick and skin picking in OCD. So some research is showing that people with OCD are more likely to have comorbid skin picking disorder, less likely to have comorbid trichotillomania, and then vice versa. It's kind of iffy looking at it the other way. But then that also kind of shows us that even though we often group BFRBs, they might not be, two sides of the same coin. Trick and skin picking might be pretty different.
I was going to make the point, this is kind of going back a point, but I think one of the other kind of I'm sorry, all I do is talk about the gaps in the field, but one other gap in the field is really our knowledge of these prevalence estimates and whatnot. So John led some studies in the last few years looking, using a national registry to try and understand kind of the rates of these disorders, and our groups at Yale did meta-analyses to try and understand the prevalence of these. But traditionally, these disorders have not been included in kind of structured assessments, and so kind of large epidemiologic studies. So we actually don't have like what you have in OCD in terms of prevalence estimates and rates of co-occurring. We don't have that. And so we're often making comments on a lot of kind of smaller studies that have been done that have some bias in them. And so these are other really important questions for the field as well.
Yeah, that's such a good point. And like before DSM-5, skin picking disorder wasn't a diagnosis. So a lot of studies before that assessing comorbidity aren't including that. Or studies looking at trick were considering it as, an impulse control disorder. So some studies might report people with OCD who have any impulse control disorder, but not specify if that impulse control disorder was trichotillomania.
Right.
So we're a little behind.
Yeah, I mean, I think it is a big step. I mean, we talked about the limitations of how it was characterized in the DSM, but having these in the DSM is really helpful for being able to study them and being able to study them in similar ways across studies, right? In a way that you can compare so that really all studies are doing it similarly, so we can start to get at findings that replicate in a way that's meaningful. So.
I feel like good training for med school, because every question I ask has an answer that's far more complicated than I was expecting it to be. And just makes it all more confusing. C and MA at 1224 asked a question, which I also feel like is going to have a confusing answer. But I want to ask it, do we know what causes the onset of BFRBs?
We don't. And I think that is, I've always thought one of the most interesting aspects in this, to Katie's point, picking and trick may be different as well.
That was interesting.
But, one of the things about trichotillomania that's often been noted is the vast majority of people are female, according to most research currently, without the big epidemiological data. And it starts basically during puberty, which begs for detailed assessments, right, of what that means hormonally, from a stress response, etc. Right? I mean, you can get it at any age, of course, but it's usually around puberty for most folks.
Yeah, and I'm very interested in that question as well. And I think part of what's really interesting about that question and kind of striking about the female predominance is a lot of the other disorders we've been talking about today are actually male dominant when they happen in childhood, right? So tic disorders, very male dominant, even pediatric OCD. Although OCD in general has a gender balance, we think of the pediatric onset being male dominant. ADHD, we've talked about male dominant. So a lot of these disorders are male dominant, but it seems that the BFRBs seem to have more of a female predominance. And so what's different about that? What is a really interesting biological question. And I think this issue of puberty, a lot of these disorders change around puberty. What's happening there? I think is fascinating as well.
Yeah, that's super interesting that it would be female dominated. And then like the onset during puberty obviously begs a lot of questions as well. And then if we had another show, Katie, I'd want to ask more questions about, what's up with maybe skin picking and hair pulling aren't actually two sides of the same coin. Like, what are some of those differences? But unfortunately, we're pressing up against time. And because we've had a kind of like information dense show, I want to go around the panel and just ask you all, for people who are watching, whether they be clinicians or people with these disorders, what's one thing you want them to take away from it's a really interesting panel. I'll start with who have I picked on the least? Emily, I'm going to start with you, even though I don't think I picked on you the least.
Well, I guess as a takeaway point, I'm really glad so many people are here today to learn more about these disorders. I think that's exactly what we need, is we need kind of more attention to them. And for everyone who did participate in research, thank you. I mentioned before, I think all of us on this panel have ongoing research studies. So if you are interested in participating in more research, I know the studies I'm involved with are listed on the IOCDF website. Just thank you for your time. And I hope this was useful to you.
Yeah. do research at Yale. John, what's your take-home point?
I think that sometimes we can get mired in the research questions that are still there, and there are tons of them. But I think the takeaway, I would say, for clinicians and people who struggle with these, we do have good behavior therapies. We have medications that may make a dent. And so I think that people can find relief to whatever degree is always the question. So I don't think they have to wait until all of this is ironed out. And I would sort of just have clinicians screen for it. And I would say when people are struggling, keep going to finding people who know what they're doing. Sometimes it feels like you did therapy. It may not have helped, but it may have been with somebody who really didn't do the right evidence-based approaches. And so I think we just really want to keep hammering that. We have ways to help people now. Maybe not perfect, but they don't have to wait until things get perfect.
Yeah, it's certainly a nice point. Strange sound. Katie, what's your take-home point?
Sorry, there's like a tornado warning or something, some siren going on right now. So I'm sorry if you can hear that. But quick takeaway, just people with BFRBs, they're more common than people realize. So you're not alone. And let's keep having these conversations. Let's keep talking about them, and let's keep hammering away at the research in the background.
Yeah, definitely.
Sorry about the siren.
No, you're totally good. I'm very glad that we had this discussion. I certainly learned a lot. I hope everyone who watched did. The IOCDF, just some closing announcements. We're a donor-supported nonprofit organization, so please consider, if you can, making a donation at iocdf.org/donate. And we'd love to hear from you. You can take our live stream survey and tell us what you'd like to see on this platform and our other live streams. You can look at that, find that survey at iocdf.org/live stream survey. We also have our 29th annual OCD conference, and I hope to see all my panelists there. It's an excellent opportunity to engage with the whole OCD community, and you can register today at iocdf.org/OCDcon. We're 2 minutes over, so I'll let my panelists go, but thank you all for joining, and thanks everyone for tuning in and viewing and asking really interesting questions. And we'll see you next month.